Good evening, all of you. I hope I'm audible as well as visible. So kindly confirm once in the chat box so that I can just start of the session. Yeah, I hope the audio is all clear. So welcome to this first lecture in dermatology of the Farre series. So as you know, for your final prof, when you're coming closer to your exams, it is very important to know how you have to write this exam, isn't it? Because it is way too different when it comes to an objective type of an examination and a subjective type of an examination. So when it comes to our subject called dermatology, there are very commonly asked topics in dermatology, which all of you know that a lot of papillosquamous diseases like psoriasis, lichen planus, many autoimmune diseases like vitiligo, alopecia, all these are very commonly asked for your final prof examinations. So thank you, Suhail, for confirming. And what I'll do today is the topic that I've chosen for today is vitiligo and alopecia areata. So we'll just try to understand what are the things that is mandatory for you to know. So before you go for your exams, and how can we approach it? Whatever questions may be asked from these topics. So it's important that how should be our approach to these kind of exams. So, so hi Nihal. Yeah. See, right now, I think that you should be focusing more on building your concepts, isn't it? So it is very important that you understand each and every subject and thoroughly with the concepts. Only then you'll be able to, crack NEET PG exams, especially when it comes to NEET PG and all. Whatever they ask you is again the basics, the basic concepts. Because right now, if you are in the third year, I feel that you should be, giving more of your time in concept building, reading textbooks and going through all these things. And finally, in case you can find time, you can also practice some of the MCQs from whichever subject you are learning right now. So I hope that is clear. So two classes, yeah, because I'm having a class session today and another session day after tomorrow. So what I'll do is I'll be covering vitiligo and alopecia today, and by day after tomorrow I'll be covering psoriasis and lichen planus. Okay. So now let us slowly get started. So now let's move to the first one. So what is our learning objective here? See, the first thing is that we have to understand what is the expected exam questions. Like for today's topic, that is vitiligo and alopecia areata, let us try to predict which type of questions are possible to be asked for your final prof exams. And along with that, let us also understand how you have to structure it. Because when you get a pen in your hand, how are you going to write the exam in a very convincing way for the examiner as well, isn't it? So they may be asking you regarding the diagnosis and management. So are you directly going to jump into the diagnosis and management, or are you going to present it in a better way? That is how we are going to discuss. And finally, we have to master the clinical knowledge, isn't it? So any disease, any condition that may be asked for your exam, you should be having an adequate knowledge regarding that topic. Only then you will be able to mold it accordingly. I hope all of you agreed with me regarding that, isn't it? So now let's see what are we going to learn today. The first topic that we are going to learn today is a disease called as vitiligo. So Dr. Loading, this is mainly, this lecture is mostly intended not to address your MCQs, but we will be going in such a way how we can approach the university level exams, okay, the subjective way, regarding long answer question, short answer question and all. So that is how, but anyways, the entire subject or the topic will be covered here, okay. So when we come in for vitiligo, any guess, like when it comes to vitiligo, what are the kind of questions you may expect, isn't it? So before writing anything, let me just start with expected type of questions. It can be a long answer question, it can be a short notes, or it can also be a clinical scenario, isn't it? So here, so hi Shiv, I'm doing good. Thank you so much. So now let's see what is the type of questions. Like you may get a question like explain the clinical types of vitiligo and its management. Very general. Types of vitiligo and its management, which means that you should have read that entire topic properly. The other type is that the question may not tell you the diagnosis. Instead, the question can give you a clinical scenario. Just read out the question. A 25-year-old presents with deep pigmented patches on the face and the hands. Okay, deep pigmented patches. Deep pigmentation means you have to think about vitiligo. So probably this is about a acrofacial vitiligo that is asked. So discuss the approach to diagnosis and management. So these are the kind of questions that you can expect from this topic called as vitiligo. So now, if you understand that, so now let us see how can we approach this subject and how can we give the answers in a right way. First and very foremost thing, since it is our first lecture on Farre series, I would just like to give you some examples like how we have to structure the answers in the exam, isn't it? So that is also very important. Now, whatever be the question, if you understand key topic vitiligo के बारे में पूछा है, then please try to do one thing. Always try to give a short introduction. It's short introduction. So what do you mean by introduction? Like what is vitiligo? Like all of you, any idea ki, what exactly is vitiligo? What kind of a disease is it? Is it an infection? Like can vitiligo spread from one person to the other? Or is it genetically acquired? Or is it an autoimmune disease? Or something else? So anyone, like I can see many of you are messaging in the chat. Can anybody answer ki what is vitiligo? What type of a disease is it? Yeah, so vitiligo is going to be a autoimmune disease, है ना? So we will definitely, for whatever topic you may get for your exam, you are going to give very good shift. It is going to be autoimmune. So you will give a short introduction. Vitiligo is an autoimmune disease and all those things. After introduction, it's very important that you try to write something about its etiology or pathogenesis. So we are writing about the introduction, then we are writing about the etiology or the pathogenesis. Then you will be writing about the clinical features, which you know, like how does a patient present to you with vitiligo. After writing the clinical features, you can also write how do you make out a diagnosis, isn't it? So you can also write the diagnosis. And in case when you write the diagnosis, you can also add up some differential diagnosis also. Differential diagnosis, and finally you would be reaching towards the management of this disease. Finally you can reach out to the management. So please make sure, all of you, so whenever you get any question, any topic, be it psoriasis, be it lichen planus, be it pityriasis versicolor, या फिर vitiligo or alopecia areata, whatever it is, always give an introduction followed by etiology, and then followed by the clinical features, then write down the diagnosis, if possible, differential diagnosis, and finally the management. So when you give this answer in such a way, what happens is that the paper becomes very much impressive for the examiner also. And that is how you can score higher marks as well, isn't it? So now let us jump into this topic now. Let us go step by step exactly the way I have described to you. So vitiligo, how can we define this disease called as vitiligo? And how can we give a short introduction about vitiligo? So first, with your permission, I'm just gonna start. So I'm just gonna write about a short introduction about vitiligo. So what is my introduction? Vitiligo is it an acute or a chronic disease? Like somebody who has got a vitiligo patch, is it going to be present there only for a week, or is it going to be there for several months together? Obviously, a lot of months together, right? So vitiligo is a chronic autoimmune disorder. Okay, there is a chronic autoimmune disorder, and the patient may present with depigmented macules or patches. Okay? The patient may present with depigmented macules or patches. And along with that, when I'm writing this word depigmented, so usually what happens in our skin, like the skin can either have pigmentation which is darker या फिर pigmentation which is lighter. अभी darker pigmentation को क्या बोलते हैं? What is a word that we use for darker pigmentation? Anyone in the chat box, please? Darker pigmentation को हम usually क्या बोलते हैं? What is the terminology? Darker pigmentation we call it as hyperpigmented, ठीक है? And lesser pigmentation than the skin we call it as hypopigmentation. पर यहाँ पे I mentioned that the patient may present to you with the depigmented macules. Depigmentation मतलब there is no pigmentation at all. So because of that word, I can also write the reason behind depigmentation. There is selective destruction of melanocytes. Okay. Why does a patient develop vitiligo? Very good. Generic nursing is answering hypopigmented. So why is there a depigmented patch? There is a depigmented patch because there is a selective destruction of melanocyte. Now all of you understand that vitiligo is a disease of dash cell. Which cell is that? Vitiligo is a disease of melanocytes. It is a disease of melanocytes. Now we can, along in the introduction, what do you think? Does vitiligo have any cosmetological or psychological distress that is associated with it? Otherwise, let us say if somebody is having a darker skin tone, what happens when there is a depigmented patch? It becomes way too easily visible. So because of which this disease is associated with psychological distress. So this is going to be a basic introduction about vitiligo. So what did we do in this introduction? Just we described कि vitiligo एक autoimmune disease है, which is chronic in nature, and the patient usually presents in vitiligo with a hypopigmented या फिर a depigmented patch. Okay, and depigmented patches क्योंकि यहाँ पे selective destruction of melanocytes होता है, and this disease is associated with a psychological distress. So this can be an adequate good introduction for vitiligo. Is that clear? So if there is any confusion, you can let me know in the chat box. Now let me just move into the next step. So introduction देने के बाद we are going to give something regarding etiology or the pathogenesis, है ना? So etiology and pathogenesis, what is the main point that the examiner is looking for? Are you going to write that vitiligo is associated with genetic and all those things? The first and the foremost point in bold should be the etiology. There is a autoimmunity. So there is autoimmunity here. So whenever there is a autoimmunity, what is happening in autoimmunity? Our body is attacking our own cells. So यहाँ पे our body is attacking which cells? Our body is attacking the melanocytes, correct? So our body is going to attack its melanocytes. So here in the autoimmunity, just note down that there is a T cell mediated. So what is happening in this autoimmunity? That there is a T cell mediated destruction of melanocytes. There is a T cell mediated destruction of melanocytes. And along with autoimmunity, other factors are also involved. So what are the other factors which is going to be involved here? The other factors which can be involved are sometimes there is some genetic factors, because these kind of autoimmunity, the patient may also have some polygenic kind of a inheritance. Like there has been findings that there is some mutations in NLRP1 gene and all, but just mention ki other factors mein genetic factor is definitely going to be included. And along with genetic factors, there can be neurogenic factors. Neurogenic factors क्यों बोल रहा हूं? because neurogenic factors में क्या होता है, there are some neurogenic polypeptides, isn't it? So whenever there is some neuropolypeptides that is being released, okay, neuropeptides which is going to be toxic to the melanocytes are getting released in this disease. And along with that, there can be some environmental triggers also. Environmental triggers. ये जो environmental triggers है, we'll talk about it. जैसे we have a phenomenon called as Koebner's phenomenon. So all those things that can be considered to be an environmental trigger. Okay, so all these are considered to be taking part in the pathogenesis, but the most and the foremost important one is going to be autoimmunity. Our body attacking our own cells. Which cells are getting attacked? The cells that is getting attacked is melanocytes. And that is why there is a destruction of the melanocyte and the patient can present to you with depigmented skin lesions. The depigmented skin lesions. Very good evening. Okay, my friend with a macule worries more than me. Okay, but anyways, what happens now in any patient who is having these kind of hypopigmented or depigmented patches, we cannot blame the patient because there is a lot of social stigma that is associated with it, and the patients are usually confused whether this is going to be something which spreads from one person to the other. Because just wait for some time, I'm going to ask you what are the common differential diagnoses. But before we go into differential diagnosis, let us also see what are the common clinical features. Now, this is a very probable question. Describe the clinical features associated with vitiligo and its management. So when it comes to clinical features, always write down what are the clinical types. Clinical types. Now, let us see what are the various clinical types of vitiligo and the best way to learn dermatology. Like if you guys are going through textbooks and or going through any materials and all, the best way to learn dermatology is always with images. Clear? So I'll just zoom out this image for you now. So once I zoom in this image, just see this image. This photographic memory is more than enough for your exam day. Okay, so just see this image. Now in the first type of vitiligo, what is happening? The entire skin is normal, correct? In this entire skin, you can see that there is one or two areas of depigmented skin. Right? So for this type of vitiligo, we call it as focal vitiligo. So first, in the clinical types, just write down there is focal vitiligo. So what is focal vitiligo? Just give it a description that few lesions, few depigmented lesions are present over the trunk. So when only very few depigmented lesions are present over the trunk, we call it as a focal vitiligo. Now let us see what is the second type of clinical presentation in vitiligo. Once again, I'm going to zoom this image for you. Now see the second image. I'm talking about this image now. In the second image, can anybody tell me in the chat box what is the finding that you see here? The entire body is normal. And where do you find a depigmentation? If you find any depigmentation over the skin, is it something very peculiar? It's very, very peculiar. So I'll get to that point in some time because that is the fifth type of vitiligo that I'm going to discuss. Can anybody answer this question? So what is the peculiarity that you see? The entire skin may be normal, but you can see that the lesions are present only over one side. It does not cross the midline. And it is a very peculiar arrangement. Excellent. Shiv, med student, all of you are answering. It is along a dermatomal distribution. And for this type, we call it as a segmental vitiligo. Okay? So now just write down the second one. The second type of vitiligo is called as segmental vitiligo, where the lesions are having a dermatomal distribution. So lesions over dermatomal distribution, and the lesions do not cross the midline. See, rather than writing big stories here, see how are we writing the notes here? Clinical types, first one focal, just one or two lesions would be present in the body. The second one, segmental vitiligo. In segmental, we are having the distribution along a dermatome or the nerve root, and the lesions are not usually crossing the midline of the body. And now let's see the third type of vitiligo. I'm just zooming it for you. Now I'm talking about this image here. Okay, this image. Now in this image, where do you find the lesions? First lesion you can see over the face, correct? Here, over the face. And where do you find the remaining lesions? The remaining lesions are present over the extremities of the patient. Now what do you call for this kind of vitiligo? Where you have it over the face and extremities. Remember, extremities means acral. Okay, the terminology that is used for extremities, like the extremities of the upper limb and the lower limb, this is called as acral. So this one is called as acrofacial vitiligo. So the third type of vitiligo is acrofacial vitiligo, where the face and extremities are involved. Clear? The face and extremities are involved. This is called as acrofacial vitiligo. And please remember, this type of vitiligo is having a poor prognosis. So this is having a poor prognosis. And along with poor prognosis, you can also mention mucosa may also be involved. All adequate points are here. The face and the extremities are involved, and this is a type of vitiligo which is having a relatively poor prognosis. And what happens? Mucosa. Which mucosa am I mentioning here? Acrofacial vitiligo mein. What is the mucosa I mentioned here? Can somebody tell me? Yes, very good. In shingles also, herpes zoster also is having a dermatomal distribution. Excellent. Now here, which is a mucosa I'm mentioning here? In the acrofacial, the oral mucosa. Sometimes the lips, the oral cavity can also be involved. That is why I'm mentioning that mucosa can also be involved in this one. So now let's jump back to the same image once again. Now let's talk about this image now. So in this image, so in this image, what is happening here? So when a patient is having a deep pigmented patch over the right axillary part, there is a deep pigmented patch over the left as well. Okay, over the right elbow, there is on the left elbow as well. Matlab, the lesions are going to be symmetrical. So whenever you find symmetrical kind of deep pigmented lesions, we call it as vitiligo vulgaris. So please write down the next type of vitiligo. So this type of vitiligo is vitiligo vulgaris. Now what is happening in vitiligo vulgaris? There are symmetrical depigmented lesions. Now, why is the name called as vulgaris? So, is it because it looks very vulgar? So, why is the name vulgaris? Does it look vulgar? इसीलिए vulgaris बोल रहे हैं या फिर कोई दूसरा reason है? So remember, vulgaris in dermatology means most common. So, this is the most common type of vitiligo. So this is going to be the most common type of vitiligo. Excellent. So Kalai, Shiv, all of you are answering. That is going to be the most common type. Okay. So now let us go to the last one, the last clinical presentation in vitiligo. Now ये जो last image है, in this last image आपको ये पता नहीं चलेगा कि what is normal, what is abnormal, क्योंकि almost the entire body has become depigmented now. Only small area of a normal skin is seen. Now, how do we describe this? This one is called as universalis. So just write down The fifth type of vitiligo is called as vitiligo universalis. So in vitiligo universalis क्या होता है कि 90% of the body surface area is depigmented. 90% depigmented हो गया. अब ये बोलो कि in the start of the session मैंने बोला कि vitiligo is a autoimmune disease. अभी कौन सा vitiligo में autoimmunity is at its peak? जैसे is it going to be focal vitiligo, is it going to be segmental vitiligo, is it acrofacial vitiligo, या फिर vitiligo universalis? So if the body, the entire melanocytes are getting attacked, then where is the maximum autoimmunity? Yes, the maximum autoimmunity is going to be in vitiligo universalis. So in vitiligo universalis there is maximum autoimmunity. Maximum autoimmunity. So these are the clinical variants of vitiligo. I hope this is clear to all of you. So please make sure that you divide them and try to have this photographic memory in your mind where focal, acrofacial, segmental and vitiligo vulgaris and vitiligo universalis will come to your mind. Okay? So now let us also write down whenever you describe the clinical features, always remember along with the clinical features it is better to add the clinical signs. क्योंकि क्या होता है especially in our department, that is in dermatology, when the patient comes to your clinic you observe these signs, isn't it? There is no history given. Yeah, I'm having all these things in my skin. So you are identifying कि हाँ ये तो depigmented patches हो गया, and these are some signs that is seen. Now the question is, what is this clinical sign that you can see here? Any guess? Anybody in the chat box? I'd be happy enough if you are able to diagnose this clinical sign in the skin. Okay. So anyone in the chat box, I'll give you a few seconds to answer. So this one is a typical sign. How do we do it? Is that always whenever you see a patient or a image, just try to describe it. Okay. In the center, you can see there is a deep pigmented skin. Okay, white color, depigmented skin. Immediately after the depigmented skin, I will just draw the borders here. ये देख रहे हो आप? तो यहाँ पे क्या हो रहा है? The skin is more darker. Very good, Kalai. I got the answer in the chat box. So glad for that. It is a trichrome appearance. Okay, very good. Excellent. So I'll just write down. In immediately after the depigmented skin, you can see a tanned skin. What do you mean by tanned skin? When you go to the sun we get tanned, isn't it? So this is called a darker skin. और उसके बाद what do you see? This is a normal skin. अभी in this patient how many colors do you see? 1, 2 and 3. So altogether there are 3 colors. So this is called as trichrome sign. So one of the signs that you can see in patients of vitiligo is called as trichrome sign, where you can see 3 colors over the skin, which includes a depigmentation, tanned skin and a normal skin. So ये हो गया one of the signs of the clinical signs. The next clinical sign that we can see in a patient of vitiligo. अब देखो कि any patient of vitiligo, if at all you have already seen cases, always remember vitiligo patients should always be very cautious with trauma, because whenever there is trauma or an injury, what happens, the patient can develop vitiligo lesions at the site of injury. Does it ring a bell? Like, have you heard about this somewhere? Maybe you have read it in your textbooks. So this is called another phenomenon. Now who can answer about this phenomenon now? अब ये क्या है? So this phenomenon is called as Koebner phenomenon. This is called as Koebner phenomenon. So what is Koebner phenomenon? That is lesions appearing at the site of trauma. So So lesions appearing at the site of trauma is called as Koebner phenomenon, and this phenomenon can also be seen. So yeah, very good. So this is also called as isomorphic phenomenon. Okay, excellent. So glad to get these answers in the chat box. So this is also called as isomorphic phenomenon. So when it comes to vitiligo, all of you, please remember there are two clinical signs. Okay, what is the first sign? The first sign is trichrome sign, where you get three different colors in the skin. Isliye trichrome, tri for three. So trichrome sign. The second one is called Koebner's phenomenon. Koebner means new lesion appearing at the site of trauma. So imagine karo, if you punch a patient of vitiligo and that trauma ke wajah se there is a possibility that the patient can develop a depigmented patch at the site of trauma. या फिर imagine करो एक दूसरा example, a vitiligo patient is scratching over the skin. इस scratching की वजह से क्या होगा? The patient can develop linear depigmentation over the skin. That is also Koebner phenomenon. Okay, so these are examples of Koebner phenomenon. All clear? So now let's move to the next part. अब क्या हुआ? Initially introduction के बारे में बात किया, फिर etiology of pathogenesis के बारे में बात हो गया. Now we discussed about clinical features of vitiligo. Clinical features के साथ हमने discuss किया clinical signs के बारे में. अब ये बोलो कि what are the diseases in dermatology which is having a very close resemblance to vitiligo? मतलब what are the differential diagnosis? So can anybody tell me the differential diagnosis? Any answers? So just write down the common differential diagnosis. First and the foremost, there is a social stigma that is associated. People are afraid. Can I handshake with the patient of vitiligo? So can I have a very close contact with the patient of vitiligo? Why is that kind of a tendency there in the society? Because there is one disease. What is it? Albinism. Okay, let us say albinism is one of a differential diagnosis, but please remember albinism will have generalized depigmentation. Excellent. It's a good differential diagnosis, but remember albinism will have a generalized depigmentation. Okay. Now the another one very important is hypopigmented patches. And now this thing is very important. You should always think about leprosy, because in leprosy what happens, the patient may have multiple hypopigmented patches, and these hypopigmented patches may also raise a suspicion कि क्या ये vitiligo हो सकता है ना? Excellent. Kala is answering. So leprosy, the social stigma. Excellent. Very good. One more. I will give you a clue. This is a very common fungal infection. So very common fungal infection caused because of a commensal fungus. So which also very closely resembles vitiligo. Especially this fungal infection is seen over the upper back, upper part of the trunk and all. Hypopigmentation दिखता है. So anybody who would like to answer? If not, I'll give you the answer. This is going to be pityriasis. Not candida. It is going to be pityriasis versicolor. So this is going to be pityriasis versicolor या फिर tinea versicolor. So these are going to be some of the common diseases which can be kept as a differential diagnosis for when it comes to vitiligo. That clear? Okay, very good. So now let's move into the management. Now that we understand that this is going to be vitiligo, and just remember when we are talking about the diagnosis, you can also do, there are two investigations which you can ideally do. One is called as a Woods lamp examination. So what is Woods lamp examination? Woods lamp examination mein we take this instrument, we turn on the light of this instrument over the diseased skin. Usually क्या होता है, there is a fluorescence, colored fluorescence that can be seen, like blue color, green color, yellow color. So these all will give you the clue towards the diagnosis. So in Woods lamp examination, what is the color of fluorescence that we get? We get a white fluorescence. So we get a whitish kind of a fluorescence. But anyways, for a confirmatory diagnosis, we can also go for a skin biopsy as well. Okay? So now let's jump into, yeah, ivory white to be very specific. Excellent. So now let's jump into the management. Now, all of you guys, when we talk about management, again, try to go in a specific manner when it comes to a subjective exam. Okay, so management को आप divide कर सकते हो medical management, surgical management. That is one. Okay, we can divide this as medical management and surgical management. That is one broad way how you can divide it. In medical management, when it comes to dermatology, always start with topical agents. So in medical management, start with topical agents. अभी topical agents का मतलब क्या है? Topical means जो हमारा creams, ointments, emollients होता है, all those things which we apply over the skin. So these are topical agents which can be used for the management of vitiligo. Does anybody know some of the topical agents which can be used? Any answer in the chat box, please? So vitiligo में कौन सा creams या फिर ointments use कर सकते हो? First thing is ये एक autoimmune disease है ना? So autoimmune disease means we can definitely go for steroids. So steroid creams, I agree. Steroid creams. Another very important thing that you have to mention in the answer is calcineurin inhibitors. Calcineurin inhibitors. So in calcineurin inhibitors, what are the most common calcineurin inhibitors? You can mention it as tacrolimus or pimicrolimus. So all these are very good. Med student is answering it as tacrolimus. So tacrolimus, pimicrolimus, they all are calcineurin inhibitors which can be used. ये हो गया medical therapy. So along with topical agents, अगर समझो कि we are having a 20-gram tube. The 20-gram का tube, is it enough when you have a very large body surface area? अभी elbow में lesions है, axilla में lesions है, अभी trunk के ऊपर भी lesions है. 20-gram tube is never enough. So what happens? We switch from topical to oral agents. Oral agents. So what are the oral agents that we can use for the management? So any answer for oral agents? Yeah, in the oral agents also, we can go for oral steroids. Oral steroids. Okay. So in the oral agents, you can go for oral steroids. And remember, other than that, there are some emerging drugs. Emerging drugs. So what are the emerging drugs? So these are some extra bonus points for you for your exam. So in the emerging drugs, always try to give an answer, especially for autoimmune cases. Anybody? It has been a lot of papers are being published about these emerging drugs. So this is called as JAK inhibitors. Okay, what is JAK inhibitor? JAK inhibitors are Janus kinase inhibitors. Okay, Janus kinase inhibitors. So these can be used for the management. So all these are coming under the medical management. Okay, so topical agents use किया या फिर oral medications use किया जैसे steroids, and then we have also gone for emerging drugs. These are biological agents like JAK inhibitors, Janus kinase inhibitors and all. Okay. So yeah, if you want the examples, so very good example that I have already got in the chat box. It is going to be tofacitinib. Is it okay? This is going to be a biological agent. Okay, tofacitinib is going to be one. So along with that, there can be another one also. So this is called as ruxolitinib. Ruxolitinib. So both these are biological agents which can be used for the management. Now, is there any case where you have to go for a surgical management? Surgical management for vitiligo sounds awkward, right? But surgical management bhi ho sakta hai, because whenever a patient is having a stable vitiligo, okay, So whenever a patient is having a stable vitiligo, जैसे यहाँ पे एक lesion है and this lesion has been stable for a period of more than 2 years now. So whenever there is a stable vitiligo, then you can go for something called as skin grafting also. So we don't jump into skin grafting so fast. Only if the patient is having a stable vitiligo, then only you go for a skin grafting. So other than medical and surgical management, it is better that you always add one more type of treatment. The other type of treatment is other treatment which can be used for the management. So please mention it as phototherapy. Okay, so you can go for phototherapy. So phototherapy, it can be either UVA or it can be UVB. So this phototherapy, you can divide it again into two. This is going to be narrow band UVB or PUVA. So what do you mean by PUVA? PUVA means psoralen plus UVA. So in basics, you just try to remember that UVA can also be given for phototherapy. UVB can also be given for phototherapy. UVA is usually PUVA, psoralen plus UVA, and UVB is going to be narrow band UVB, which is going to be the commonly used one. Is that clear? So that is all about this topic called as vitiligo. I hope things are clear to all of you. So in case you get any short answer question or a long answer question based on vitiligo, if they ask you the diagnosis and management, or if they ask you the clinical features and management, so in all these cases, please try to go in this format where you give a short introduction. Along with the introduction, you jump into the clinical features and then treatment. Okay, so that is how you can approach it. Yes, I completely agree with you. If there is any doubts in this topic called vitiligo, you can just let me know. Otherwise, we will move to the next topic now. आज दो टॉपिक्स हम करेंगे. The second topic that we are going to do today is going to be alopecia areata. एक इंटरेस्टिंग क्वेश्चन है कि व्हाट इज एलोपेशिया एरियाटा, क्योंकि एलोपेशिया एरियाटा अगेन वी कैन थिंक अबाउट सेम काइंड ऑफ अ पैटर्न. It can be long answer, it can be a short answer, it can be a clinical based scenario. So I'll just give you some of the examples. The example is discuss the clinical features and management of alopecia areata. Straight to the point, आपको clinical features बताना है, management कैसे है वो भी बताना है. Otherwise, they can give you a little bit of twisted one. What is it? A 30-year-old patient with a patchy hair loss and exclamation mark hair. Outline your management. Abhi, if you are getting these kind of questions where there is a clinical scenario given, it's very important that you have read that topic. वरना आपको पता भी नहीं चलेगा कि कौन से डिजीज में exclamation mark hairs है, isn't it? So that is very important that you read the entire topic. So now let's have the same approach. Now I'm not going to give you further thing again. So I just want to stick on to the same point. Introduction, etiology and pathogenesis, clinical features, diagnosis, management. Okay? So this is how we are going to approach the disease once again. So when it comes to alopecia areata और vitiligo, ये दोनों diseases में common क्या है? So what is common in both these diseases? Anybody? Please let me know in the chat box. Let us try to make it more interactive. कि alopecia areata और vitiligo में common क्या है? Anyone? So please remember, alopecia areata is also a chronic autoimmune disorder. Okay. So what is the thing that is common in both? The thing that is common in both is this one, which is called as autoimmunity. So autoimmunity is going to be the common thing. Yeah, very good. Autoimmune T cell dysfunction. So excellent. That is going to be the common thing in both the cases. And here, along with that, as I told you, just describe in one sentence कि usually alopecia areata कैसे present करते हैं. Okay, so patient usually complains of a patchy hair loss. Okay, where a patient can usually complain of a patchy hair loss. And where this patchy hair loss can be seen? It can be seen over the scalp, over the facial hair, isn't it? Scalp, facial hair and the trunk. तो स्कैल्प में हो सकता है, फेस में हो सकता है, या फिर ट्रंक में हो सकता है. दैट इज हाउ एलोपेशिया एरियाटा कैन एक्चुअली present to you. This is going to be a short introduction about alopecia areata. Now, why is alopecia areata happening? So again, we are coming into the etiology or the pathogenesis. So just like somebody answered the chat box now, yeah, Kalai has already told that this is a autoimmune T cell dysfunction. Excellent. This is what the examiner wants to see in your answer paper. Okay, so first point here, so just write down that this is due to autoimmunity. So in this autoimmunity, what is happening? There is a T cell mediated attack on what? So there is a T cell mediated attack on what? Earlier vitiligo में क्या हो रहा था? There was a T cell mediated immunity over the melanocytes. So यहाँ पे this is about hair. So what is it? On the anagen hair follicles. See, what is the meaning of anagen hair? Anagen hair का मतलब ये है कि the growth phase of the hair. Okay, so whatever hair is in the growth phase, that is going to be attacked because of this autoimmunity, and that is how the patient tend to lose out on these hairs. So that is what is happening in this one. And of course, there are associated with genetic factors also. There is some associated genetic factors also, where you can mention that there are some HLA associations. What is the HLA association? It is going to be associated with HLA. Anybody? It is going to be associated with HLA DR3 in the chat box. And sorry, HLA DQ3, not DR3. Okay. This is going to be associated with HLA DQ3 and HLA DR4. So these are the common HLA associations, HLA DQ3 and HLA DR4. You can let me know if my handwriting is bad. Okay, I'll try to make it better. Sometimes it is not readable. And other than that, in all those autoimmunity, there is obviously some environmental triggers as well. There is always an environmental trigger. So this is going to be the pathogenesis of which disease? The disease called as alopecia areata. Now, after pathogenesis, where are we going to jump into? We are going to jump into the clinical features. Now, let's see what is alopecia areata. I have just given you some of the images. क्योंकि dermatology है, your that photogenic memory should definitely work. Correct? So these are different types of alopecia, just like how we dealt with vitiligo. Same format में let us write down the types of alopecia areata. शुरू करते हैं first type. The first one is the classical alopecia areata, where the patient presents with complaints of patchy hair loss. Patient can come to you with complaints of a patchy hair loss, isn't it? So I'll just zoom the first image for you. This one is the classical one. So what is happening in this classical one? These are different patchy hair loss. Multiple patchy hair loss, always going to be alopecia areata. और ये भी याद रखना कि if there is a male patient who comes to you with a small patchy hair loss over the beard area, फिर भी diagnosis क्या है? It's going to be the same. It is going to be alopecia areata. So that is going to be the first type of alopecia areata. The second type of alopecia areata is going to be called as alopecia totalis. So what is happening in alopecia totalis? जो small patchy hair loss हो रहा था पहले, this patchy hair loss because of increased autoimmunity. अभी क्या हो रहा है? The entire scalp hair is being lost in the process. This is called as alopecia totalis. So in alopecia totalis, just mention loss of entire scalp hair. That is going to be alopecia totalis. Now, another type of alopecia areata is where the autoimmunity is at the peak. Okay, just like vitiligo universalis. क्योंकि vitiligo universalis में क्या हो रहा था? 90% of the body was turning depigmented. Same way, if there is very severe autoimmunity, क्या हो सकता है? The patient can lose the entire scalp hair. The patient can also lose the eyebrows, eyelashes, the beard, mustache, and the entire body hair. Everything is lost, which means the loss of complete body hair is called as alopecia universalis. Okay, the last one is alopecia universalis. So we learned about two universalis today. Okay, this is the second one, alopecia universalis. So what is happening in alopecia universalis? Loss of complete body hair. Loss of complete body hair is going to be called as alopecia universalis. Now, these are the common ones. Okay, even if you write these three types of alopecia areata, still adequately sufficient. But there is also two more variants of alopecia areata which can be seen, and these are called as, I'll just add it because when we learn, it's better we learn everything together, isn't it? क्यों one or two classification को छोड़ना है? So now let us learn about two more less common, less important ones, but it will be an added advantage if you write this one. So this is called as ophiasis type of alopecia areata. Now, what is happening in ophiasis type of alopecia areata? There is loss of temporal and occipital hair. So what is happening here? There is a loss of temporal and occipital hair. So there is a band-like hair loss. So there is a band-like hair loss. Now you will understand this better if I zoom in this image. So imagine करो ये एक patient है. So what has happened to this patient? This area, the temporal area and the occipital area, the patient has lost the hair over this area. This is called as ophiasis. Now imagine the exact opposite one. Okay, exact opposite one. See, what is going to be exact opposite? Just read this word. The name of this disease is ophiasis. Ophiasis को exactly rotate करो. SISAIPHO. So this is called that Sisypho type of alopecia areata. Okay, Sisypho. So Sisypho. So I'm just writing the next one. The fifth one is called as Sisypho. Because if you remember ophiasis, you remember Sisypho also. Because it is exactly opposite when you rearrange the words from the last towards the front. So Sisypho type में क्या हो रहा है? The exact opposite. Where is the patient losing the hair? The patient is losing the hair over the central part. And what is happening? There is a retention of hair. There is a retention of the hair. Where is the retention? Over the temporal and occipital areas. So these are going to be the various types of alopecia areata. So why does progression from alopecia areata to... See, the story of life, you have asked why is the progression different? Now you know that we are talking about autoimmune diseases. कि चाहे medicine में हो या फिर surgery में हो या फिर dermatology में, in every subject the concept is going to be the same. Autoimmunity का मतलब क्या है? That the patient's body is attacking our own cells. That is going to be the same scenario when you take any disease. जैसे Hashimoto thyroiditis भी ले लो. So everywhere, whenever there is an autoimmunity, our body is attacking our own cells. Now, this autoimmunity, it varies. It is going to be, chronic as well as it varies in its intensity. And that completely depends upon our body. And it is not something that is predictable. So in some of the patients, they go into very severe autoimmunity. Some of the patients, they do not. So that is why some cases we give some steroid tablets and all, or some immunosuppressive agents. That is far more than enough. But in some cases, it is not going to regress. You'll have to go for some newer therapies, biological agents and all. And this is not something which can be explained for the reason for extreme autoimmunity in some of the cases. It also depends upon the type of immune response that our body has. I hope it answers. So now these are the clinical variants of alopecia areata. So we discussed classical हो गया, alopecia totalis हो गया, alopecia universalis, ophiacis, and the last one is Sisypho. These are the 5 clinical variants. So now also let us see another clinical signs. जैसे पहले हमने किया था trichrome sign, all those things. What are the other clinical findings? So your heading should be other clinical findings in alopecia areata. So what are the other clinical findings? First, you just give, wherever it is possible, just try to give a subtype, okay, subset. So here you can just write it as nails. So in the nails, what can you find? In the nails, you can find something called as pitting. Pitting means depression over the nails. So this can be a regular and shallow nail pitting. So this is going to be regular and shallow type of a nail pitting can be seen in the patients of alopecia areata. And another finding in the hair, another finding in the hair, which was mentioned in our question earlier. Remember, exclamation mark hair. So when you do a microscopy of this hair, what you can see is that here you can see that this is called as exclamation mark hair. Now all of you know what is an exclamation mark, isn't it? So how does an exclamation mark looks like? Exclamation mark, it looks like something like this. This is our exclamation mark. So what happens in an exclamation mark here is that the proximal end of the hair is becoming thinner. The proximal end of the hair is becoming thinner, and the distal end of the hair is thicker under a microscopy. This is called as exclamation mark hair. So this one is called exclamation mark hair. Another very important finding in alopecia areata. Now earlier in the chat box, somebody was writing about one more sign. Another sign in the case of alopecia areata is called as turning gray phenomenon. So what do you mean by turning gray phenomenon? Like imagine that you are getting a patient who has come to you with complaints of a patchy hair loss. So when you see a patient with a patchy hair loss, you can see that the entire black hair is lost and the white hair is retained. So this one is called as turning gray phenomenon, where there is loss of black hair and retention of white hair within the patchy hair loss. So this is called as turning gray phenomenon. Clear? Story of life. Why does ophiacis cause band-like hair loss while others cause patchy? See, ophiacis and Sisypho, these are not at all common. As I told you, alopecia areata ka most common presentation usually patchy hair loss here. Okay. Only in severe autoimmunity, it can go into totalis or universalis. Very rarely, we find two more clinical variants. वो rare presentation है. That is called as ophiacis and Sisypho, but very rare. And since we have this kind of a pattern, that is why we call it like a band-like hair loss. But please try to stick on to this thing patchy hair loss for your exams. Patchy hair loss, this one single point is what is going to yield you the marks when it comes to the exam answers. Okay? So now, yeah. So now let us do the last one. When we do a investigation, where you can, when you're going to see the hair under the microscope, what you can find is something like this. So what is happening here, there is some aggregation of the cells that is seen here. So I'll just note it down here in this image. So can you see that there is an aggregation of cells? Now this aggregation of cells around the hair, this some is looking something like this. Now what is this? ये तो आपने जरूर देखा होगा. What is this? So this is going to be a group of honeybees, like, so a group of honeybees, like kind of an appearance. Yeah. So this one is called as the swarm of bees appearance, which is due to lymphocytic aggregation, which you can see in alopecia areata, which you can see in alopecia areata. So that is going to be the various types of alopecia. Now, when it comes to differential diagnosis, because most of the times क्या होता है, alopecia areata itself is a spot diagnosis. यार patient को एक patchy hair loss है, and this is going to be alopecia areata itself. Now, when it comes to differential diagnosis, we anyways have to list out few of the differentials. Now, first differential diagnosis is a disease where a patient can pull their own hair. So when the patient will pull, if I pull my own hair every time, which can be considered to be a psychiatric illness, what will happen? Because of the traumatic pulling of the hair, can I get a patchy hair loss? So what is this disease called? Can anybody answer in the chat box? ये कौन सा differential diagnosis है जहाँ पे the patient is pulling their own hair because of a psychiatric disease, and there can be a patchy hair loss that can be seen? Anyone? Any answer? It's okay even if you make it wrong, but be bold enough to give some differential diagnosis. So this one is excellent. So this is, Kala is again answering, this is called trichotillomania. Excellent answer. So this one is called as trichotillomania, where a patient can have a, it's a impulse control disorder where the patient cannot control that emotion to pull out the hair. It's considered to be a psychiatric illness. Another case where a patient can have a patchy hair loss is in an infection. कौन सा infection होगा? Bacterial infection होगा, या फिर viral infection होगा, या फिर fungal infection? So yeah, doctor is answering androgenic. I would answer androgenic is also a good differential. Androgenic alopecia can also be a differential. Now, what is the infection? Can anybody answer? Infection should be essentially fungal infection. This is called as tinea capitis. A tinea capitis can also have a patchy hair loss because of a fungus. Excellent. So I got one more very, very good differential diagnosis where you can get a moth-eaten alopecia. Moth-eaten alopecia means that is syphilis. Very good. Moth-eaten alopecia. Excellent answer. Yeah. Wonderful differential diagnosis. So that is going to be moth-eaten alopecia, which can be seen in secondary syphilis. Yeah. So all these are differential diagnosis. Now let us jump into the management. अभी management, जैसे मैंने पहले बोला था, just keep this prefixed in your mind कि मैं medically manage कर सकता हूँ या फिर surgically manage कर सकता हूँ. So let us first write down on medical management. So in fact, there is no surgical management as such, but let us see. So what are the medical management? In the medical management, the first and the foremost thing that you can say is whenever you are having a patchy hair loss, our first line of treatment is usually a injection, which is called as an intralesional steroid. Can anybody make a guess ki what is that intralesional steroid which we can use in the case of alopecia areata? Intralesional steroid. Anybody? Chat box. So I'll just write down intralesional steroid. So this intralesional steroid which we can use for the management is, if you want one more clue, I'll give you. It starts with T. It's a steroid available as an injection. Anyone? This is called triamcinolone. Okay? Triamcinolone can be used. Okay, very good. So triamcinolone injection, that is going to be our first line. Okay, this is going to be our first line for treatment. So if you get a patient with one or two patches, वो दोनों patches में one shot of intralesional steroid. Probably we will have to do multiple shots of intralesional steroid. So that is going to be one. Other than that, let us think in the same methodology. Can we apply some creams? Okay, topical agents. Topical agents. So topical agents में what should we give? Now again, I'll just pass on to you one more very important information कि कोई भी autoimmune disease में what is happening, our immune system is super active, isn't it? So when our immune system is super active and attacking our own cells, what are we trying to do? We want to bring down the immunity, or we have to increase the immunity. Obviously, if you have to bring down the attack, we will have to bring down the immunity. So we always go for immunosuppressive agents, out of which the most commonly used one is steroids. So be it any subject, medicine, surgery, dermatology, pediatrics, any subject, any autoimmune disease, treatment is always going to be immunosuppressive agents. So keep this concept in your mind. Okay? So topical agents may we can give steroid creams. We can also give calcineurin inhibitors, because we just now mentioned what are the calcineurin inhibitors that we have. Calcineurin inhibitors में कौन सा है? One is tacrolimus, the other one is pimecrolimus. वो दोनों use कर सकते हैं, because steroid creams, they come to you with a bunch of side effects, and it's a chronic condition, so we don't want much of a side effect like skin atrophy and all. That is the reason why we keep the steroid creams reserved. Okay, so that is how we can do this. We have also mentioned about intralesional steroid also. In case the body surface area is bigger, alopecia totalis, यहाँ पे कोई steroid cream use कर सकते हैं क्या? No. So in such cases, we can go for systemic steroids. Systemic steroids. For example, prednisolone. For example, prednisolone. So systemic steroids भी हो गया. And other immunosuppressive agents. Other immunosuppressive agents. So can you name a few of the immunosuppressive agents which we can use? So immunosuppressive agents में the other ones which we can use are, again, it can be azathioprine, cyclosporin, etc. So just like any other autoimmune disease, we can use azathioprine, cyclosporin, etc. for the management of this condition called as alopecia areata, and also emerging drugs. So this is for your additional marks. Okay, emerging drugs. So emerging drugs is going to be the same. What was the name of that emerging drug which we used in the management of vitiligo? Now this is a time that you will have to memorize now. So don't think that you go after the class and then learn. So let us learn it together. So what was the name of that emerging drug which is used in vitiligo? The same drug can be used in the cases of alopecia areata also. Please drop the name of that drug or the category of that drug in the chat box. So what is it? Yeah, so this is going to be JAK inhibitors itself. This is going to be JAK inhibitors. Janus kinase inhibitors can be used. So that is also used for the management. Okay, that is going to be the same. So along with that, what happens is, be it vitiligo, be it alopecia areata, we will have to give some counseling for some psychological support, because all these things are severely distressing for the patient. So that is how you can deal with alopecia areata as well. So in summary, what I would like to put across in this session is that, so you have to always start any question, be it in short form or in long form. So you always will have to start with an introduction or a definition. So please do that for any disease that is asked. And whenever possible, like we just try to give these subheadings like intralesional steroid, topical agents, systemic steroids. So because these subheadings is always going to be useful, because the examiner will feel it much more, and the paper will look much more neat when you give these subheadings for clarity, and just try to go along with the same format like introduction, etiology, pathogenesis, diagnosis, and differential diagnosis and management. Okay? That is how you can deal with most of those cases in dermatology. And we are having more sessions coming up so that we can help you with the final prof examinations. And in case there is any queries or anything that you would like me to do in the future sessions, do let me know in the chat box. So we'll have a very short interaction and we'll wind up for the day. Just let me know if there is any queries regarding the topics that we have dealt today or in any other topics. So what I'll try to do is, if there is anything much more important, I'll just try to add those lectures in the upcoming sessions as well. Okay, if there is anything that you feel particularly difficult to learn or anything, I'll be happy to help you. So if there is, please make sure that in our app, so we have given you this thing called as a Farre series. This has already come in the app already. And along with that Farre series, you can also go through those clinical corner as well. So what you will do is, when you go through all those topics, it becomes much more easier. We have categorized all those things separately. And for the Farre also, we will be having the most commonly asked questions all given in a single place. So that will be much more easier for you to prepare for your final exams. Okay. So I think that is it regarding today's session, and we'll see you again. The next session is day after tomorrow. So in the session day after tomorrow, we'll be dealing with very important one, that is psoriasis and lichen planus, which comes under papillosquamous diseases. Okay. So thank you so much for your patience, and we'll definitely meet you again soon for the next session. Thank you, Kalai. Thank you, Helix, Potato Chips, and all of you who has attended. Thank you so much.